Dr. Kollan Ganguly to come and hand over the mementos, please. Chairperson, Dr. Devmallo Shannal. This is an organizer and remind people to be in time. On to the next session, the inhaled insulin workshop. Well, we know that it's one of the newest things that we have got, clearing the air around inhaled insulin. And may we call upon stage Dr. Supratik Bhattacharya and Professor Anirban Mojumdar. A big round of applause, the two facilitators for the inhaled insulin workshop. And the stage is all yours, sir.
Can I have a lapel mic? Will that be okay?
Lapel mic, please.
So, good afternoon. We are going to start inhaled insulin workshop, but before we enter into the inhaled insulin workshop, let us have some discussion about the insulin also, because I think a lot of misconceptions are there with the insulin issue. So, first of all, if you got any question, you can ask any time and stop us and ask in between. So, this is the first issue. We'll go into the inhaled portion a bit late, but first we will start with the this few important understanding. And so objective, if we recall, then it is a insulin was discovered almost 100 years back in 1921, and from animal insulin to human insulin, and now we have recombinant DNA technology based insulin. And we have basically two different types of insulin available to us, mostly basal and prandial. I believe that if you are not a hardcore diabetologist or endocrinologist or for a physician, this two insulin is good enough for you for your lifetime. Don't try to learn how to use mixed insulin, premixed insulin, and co-formulations, and these are more complicated. Best is start basal insulin. If not control, add a prandial insulin. Very simple. So keep your learning very simple so that you will be able to manage more than 90% of the cases. And for less than 10% or 5% cases, I think you should take help of the other people or those who are working in this field for the whole life. They can give you good advice. So we have different types of how we can inject it, but nowadays we always use insulin pen. I don't use insulin syringes nowadays. It is just like black and white TV, so we don't see the black and white TV, we see always the color TV. So use pen. Otherwise, even today I face problem because people are using some syringes, and which create lot of confusion. And there is a confusion not only among the physician but also among the paramedical staffs, and more so among the patient. Very difficult to manage. I will not elaborate it, but be very practical and pragmatic. Now first question is when to initiate. Now can anybody volunteer when we should initiate insulin therapy Anyone?
Before that,
One-
Dada, a pop
yes.
question to you. Who was the first person to receive insulin? Raise your hand. An adolescent boy. What was his name? Fantastic. You are getting a sponsored dinner from the organizer. So second question is when? What was the date? So it was 11th of January 1922, and then the purified version by Collett was on 23rd of January 1922. So important dates to remember, because I can't think of a more relevant platform than this, because it's all about insulins and that's how it started. So fantastic, and big thanks to you for accommodating me here, and I'm sure we're going to have a fantastic discussion. But the criteria is your involvement. So we want this to be a didactic session where you are going to ask a lot of interesting questions and we're going to have a discussion rather than it being a monologue. Is that okay? Can we hear it? Yes? Fantastic.
So, Supratik, so let's start with this first question, that when to initiate, not the historical initiation, but
Yes.
rather in our day-to-day practice, that when should it initiate. So at least one answer should be there, that who should receive insulin therapy. One answer, one voice, one answer. Yes.
May I ask somebody to carry the microphone? Just raise your hand and then the microphone reaches you.
With three different groups of medicine at a higher dose.
That's good.
Persistent
Hamanta, what is your?
The patient with osmotic symptoms of hyperglycemia.
Okay.
So I think one very, even with this people may argue, but one simple answer is all type 1 diabetes. So give this answer first. Why you think about type 2? First think that who will receive insulin? All type 1. As simple as, the very simplest answer is this one. But yes, Supratik, any other situation? So we got two answer from all of you. Number one, if a type 2 diabetes who have osmotic symptom, we should start insulin. This is one. Yes, what you have said. And you said if the patient is already receiving oral anti-diabetic drug, there are many different guidelines, 2 or 3 oral anti-diabetic drug, still the patient is not controlled, we should start insulin. That's fantastic. I think if you remember these 3, type 1, osmotic symptom, and 2 to 3 drug failure. We are, so Supratik, can we
So
add
I
few
think,
more?
like
issues?
GDM patients, I think this is one of the important considerations to have. Second is anyone coming with complications, for example. So they want to undergo surgery, their sugar has to be controlled well, emergency situations where they need to be admitted and the sugar has to come down. So these are the situations where you need to consider insulin. Yeah. Because
One important indication is not discussed. Anyone can add about yes, very good. Pregnancy.
I just said.
Yes. So that's great answer. So I think these are the few answer we. So that very good. I think when we should initiate, that's a great. So regime. So what should be the regime? Ki insulin debo aage. First insulin konta start korbo. Because I have said 2. One is just think about 2, nothing more. Basal and prandial, no more. Which one to start? So everyone in basal?
I think there's no right or wrong answer to this. If you see the various guidelines, it kind of accommodates a lot of things, right? So the Indian guidelines and also the Western guidelines, they have space for a lot of things. So it's not just basal 100%. So you have to consider on a case-to-case basis. So you have to customize based on the scenario. Is that correct?
Yes.
Perfect.
So where we should give prandial more importance than basal, any situation what we have discussed? Yes, very good. So that is very good. So it means that in pregnancy, especially in GDM, people require more prandial correction rather than basal correction. On the other hand, in other situation, we should give basal first. And as Suprati was pointed out, some cases people have inclination to give premixed insulin also, but we will not discuss that. So let us keep it very simple. So this is the Shrupadeep, can you
Yeah, so I mean,
elaborate little bit on this?
if there's one slide or one take-home message they want to carry back home, it's a very busy slide. You don't need to remember the numbers at all, just that we have improved, and the endeavor has always been to mimic body's own physiology and to get as close to that as possible, and that's been the endeavor, starting from the human insulins, you know, and then going forward to the analog, you know, insulins. So we're going from, you know, 24-hour long to 27-hour plus to 36 hours plus. So we are improving on the basal component, making it flatter, smoother, so that it doesn't cause any peaks. There's no intraday or interday variability. So this is about the basal insulin. Similarly, for the prandial insulin, we are trying to make it as fast as possible to mimic body's you know, prandial insulin secretion, and so that it's very rapid acting, it does its job and then comes back down, so that it doesn't cause any hypoglycemia. So that has been the endeavor. And what is the longest insulin that we have right now, or the second generation basal insulins? Okay, so that's one of the basal insulins that we have. What else? Longer duration, more than ultra long insulins, more than 24 hours. Okay, what else?
Apart from basal insulin, any other insulin which has got a very long,
Degludec already said.
apart from degludec?
Yes, A-weekly is going to come. So it's not with us anymore. It's going to come in a while. But so we are just, I don't know, there's no end to it. So it's all about the convenience of the patient. Now we talk about it. You know, at one point of time, it was unthinkable. You know, like we couldn't imagine that we could go beyond a certain point. But we are talking once weekly insulins now. Similarly, rapid insulins, ultra rapid acting insulins. So this is what is happening. But one thing that has not changed, what is that? We have bettered on the insulin. We have bettered on the device. We have gone from, you know, the glass syringes that he was talking about into, you know, plastic syringes, disposable syringes. We're bettered on the needle. It's just a 4mm needle that we're using now, subcutaneous. But what is that has never changed about the insulins? It's been an injectable.
Injectable.
And that's what the problem is. Everybody has been bettering on the device, but they couldn't come off the fact that it's an injectable. So that was where the limitation was. And hopefully with today's session, we will have something which was groundbreaking, which is going to be changing the dynamics when it comes to insulin initiation, and hopefully get more and more people on board with insulin who need it.
So you have so many varieties of insulin, as I have said, that for me also to remember only 2 insulin is good enough. So one basal and one prandial. This I always try to teach, though there are different varieties. So it is better you learn only one in basal insulin, one prandial insulin, and this will help you for rest of your life. Now the device and the new insulin we will discuss late, but the কতটা ডোজ শুরু করব? Any idea? So anybody has any idea how much insulin is produced by the pancreas? যদি যতটা তৈরি করে ততটা দিলেই হবে মোটামুটি in most of the situation. So how much insulin pancreas produce daily? Any idea of anyone have any idea? No idea? Okay. So how much insulin a type 1 diabetes requires per day? Anyone? Type 1? না type 1 এ একটা upper limit আছে. Type 1 এ usually বেশি insulin লাগে না. You know, the type 1 is actually, there is no any beta cell. So you have to replace the amount of insulin produced by the beta cell. Unless and until there is decay or infection or any other complication, usually their requirement is more or less static. It may vary from one patient to another patient more or less. In type 2 there is no upper limit, I agree with this answer, because there is an insulin resistance. So, the amount of insulin dose will require on the amount of resistance. I agree with this, but I am asking in a type 1, what is the normal pancreas produces, that should be replaced every day more or less. So, this is about say 15 to 25 units per day. So, or you can calculate by body weight, say 0.8 units to 1 units per kg per day. That is usual requirement. So, 50% of this the patient will require basal insulin, and 50% of this the patient will require prandial insulin. That is why I have said one basal insulin, one prandial insulin is good enough to remember for management of diabetes. So, with this we will go into how to initiate. I am already told how much is the dose that more or less we require. So, if you are giving a type 2 diabetes, as you have said that there is no upper limit. So, we must have some starting point. জানি upper limit নেই, কিন্তু কিছু একটা দিয়ে তো শুরু করব. What is that amount? Say for example basal insulin, how much you will give?
I think keep it simple, 10 units, and then you can correct. I think you can go
Yes.
into all sorts of complicated calculations, and then you can
Yes,
do the
I agree.
corrections later.
100%.
Keep it simple.
মা দুর্গা 10টা হাত 10 দিয়ে শুরু করো। 10 হচ্ছে সবচেয়ে ভালো নাম্বার, সুন্দর নাম্বার, মনে রাখতে সুবিধা হয়, কোনো ঝামেলা নেই। হ্যাঁ, ইয়েস প্লিজ। Very good.
With this 10 unit, shall I stop those oral hypoglycemic and then start 10 units, or
It depends on what oral hypoglycemic they are taking.
just like metformin?
So metformin, there is no change. Then,
And shall I, if he is on metformin and not any sulfonylureas,
so they are not on sulfonylureas. Then which one are you concerned about? DPP4, there is no change.
DPP-4 there is no.
No. Incretins based therapy, no change. SGLT2 inhibitor, theoretically 20% reduction in insulin, but otherwise, if you are on sulfonylurea, that's what the challenge is. Usually, you have to down titrate when you are adding insulin on board.
So I will keep this and add 10 units insulin, sir.
Yes.
The best policy is continue all, start 10 units, then titrate the dose. Or you can reduce sulfonylurea to a small extent, say half dose of sulfonylurea. Some people say, as Supratik has pointed out, say you are giving glimepiride 2 milligram, make it 1 milligram and add the insulin. That's it. So, very good. So, we know how to initiate. Now, if the patient is not controlled, then we keep on increasing the dose of the basal insulin, and then when the fasting is controlled, we have to look for postprandial. Any postprandial is not controlled, we will give a prandial insulin we have to add. So, this is a very simple way to look into it. So,
Achha.
how to titrate?
ঠিক আছে।
Titrate to হয়ে গেল।
Titrate to বলেই দিলেন আর কি। Basically, titration has two phases. You have to achieve your fasting target as soon as possible within 12 weeks. So, you be rapid, the 2 units, rule of thumb, 2 units every 3 days or 4 units every 7 days. Within 12 weeks, try to reach your fasting target. Once you have reached, if your prandial is not corrected, then you have to think of addressing the prandial component with the prandial insulins. So, that's what the up titration is about. Okay. Is that okay with all of you? Understood?
Okay. So,
Any
any
confusion?
question, anybody, any question related to insulin? Because then and then only we will proceed further. Anybody has any question regarding initiation and titration? Any question regarding initiation and titration? No question. So, if the prandial is not well controlled, we need to optimize. The best way to optimization, I have said, the adding a prandial insulin. So, for adding prandial insulin, we are actually এটা অ্যাডভান্সের মধ্যে আর যাচ্ছি না।
না, সো ওই দুটো কম্পোনেন্ট যেটা বলা হলো, একটা যদি বেসাল উইথ বোলাস করা হয়, then you when you are up titrating dose, as we said, if you have reached your fasting target with your basal, then add a prandial component as a basal plus. basal plus 1 prandial with the largest meal of the day. If you can't reach the target, if you feel that all the 3 meals are of similar quantity or 2 large meals comparatively, then you have a basal plus plus. So 2 prandial components with the 2 largest meals of the day. And even with that, if the prandials doesn't get corrected or you don't reach your optimic glycemic goals, then you can think of a gold standard basal bolus regimen, which is basal plus 3 prandials. Now, sometimes in type 1, you might require multiple daily dosing because they might have snacking in between, which cannot be controlled with 3 basal components, 3 bolus components. So, what do you do about it? How do you handle? The person is saying, ডাক্তারবাবু আর পাচ্ছি না, আমি তো 4 বার করে নিচ্ছি, আরও নিতে হবে। So what is that you can offer? Beg your pardon? Yes. He or she has been a type 1 and has been taking insulin lifelong and been very compliant with the No, I'm saying, please listen to my question. My question is, they are snacking in between, which is high in carbs, and that's not being addressed by the 3 rapid insulins that we are giving as prandial insulins. So how do you address the carbs in those snacks? What is that you can offer which is not an injectable?
A patient is a type 1 he is talking about. So we are not discussing about the oral agents. So like pioglitazone we cannot use.
So pump, yeah, that's an excellent way, because if you don't want to
Yes.
prick, then I think that's an excellent thing to have on board. Only challenge is the cost of the pump. That always gets in the way. So another thing that you can offer, as we said, inhaled insulin. So if you don't want to increase the number of pricks, you can offer this inhaled insulin with the snacks. So that will cover you for those snacking as well. Is that okay? So are you aware of the fact that there is an inhaled insulin
Okay.
that has been
Very good.
launched in India? Are you aware of that? How many of you know that there is an inhaled insulin available now in India?
Very good.
And how many of you think the device is like this big? How big do you think is a device? Oh, fantastic. So the previous device was really big. I don't know if you have seen that. That was really big. The one that we have now, yeah, you're showing the size. Show that again. Yes. So this is the size. It fits right into your pocket. We'll have a demonstration of how to take it, but it's really convenient. It goes into your pocket. You can carry it with you at the workplace. And if a person doesn't want to, prick themselves, this is another alternate that you have to the prandial insulins. Carry on, please.
Sir, one question.
Yes, yes, please.
Should we use it along with the injectable, or should we use it
Very good
only-
question.
Basal component has to be satisfied. Okay, so you have to give a basal component. This will only satisfy for the prandial component.
So go back to the issue of type 1 diabetes. You have to give the basal insulin and you are giving prandial insulin. So instead of giving prandial insulin prick, you can use this inhaled insulin. Again, in a type 2 diabetes, you have started with the basal insulin, fasting is controlled, but the postprandial is not controlled. So if you want to control the postprandial peak, then give you want to give one short acting insulin, or you can give this inhaled insulin. If you want to correct 2 prandial peak, then either you give 2 short acting insulin or 2 inhaled insulin. If you want to, if the patient is still not controlled, as Supratik has pointed out, you have to give 3 prandial shot, or you can give 3 inhaled insulin. Or if the patient even with 3 is not controlled, like type 1 diabetes, taking an evening snacking and give another inhaled insulin during the snack. So it is not a replacement of basal insulin, it is a replacement or substitution of the prandial insulin. So this must be very, very clear. We are not stopping long-acting insulin. Don't stop long-acting insulin and give this one with the expectation that it will control the fasting plasma glucose. No, it is a short-acting insulin. It is a replacement of bolus and not the basal insulin.
Sir, can you put some highlight regarding the dose? And
Yes.
And another question, is it taken, inhaler per nasal or like inhaler oral? mouth?
Yes.
So
Oh,
we'll show you how
we'll
to
show
take
you.
it. We'll give you the demonstration. Units
Well-
are the same as injectable unit. So if somebody is requiring 4 units of injectable rapid, it's going to be the 4 units of inhaled insulin. There is no change at all. So if it is 8 unit, they will take 8 units. So it's a unit to unit swap.
Mane per puff, it's 1 unit per puff.
No.
So it comes, I will show you, there are cartridges of 4, 8 and 12. So you can go in multiples of that. Okay. Say for example, if you require 4 units, you take the 4 unit cartridge. If somebody requires 6 units, then you go to the next one. So you take a 8 unit one. So if somebody requires 8, then you have a 8 unit cartridge. If somebody requires 12, you can give 12 or 8 plus 4, whichever way you want to go. So it's very simple, we'll show you. It's going to be as simple as you had been handling insulins. What has been the biggest hindrance in your clinical practice to initiate insulin? Please raise your hand. Has it been the injectable component, the fear of injection? How many of you think the fear of injection has come in the way when it comes to injections? So I think, how many of you think that when you have an alternate route, this can be a game changer? Please raise your hand. Fantastic. I think my job is done here. Well.
So, as you have asked this question, we cannot give 1 unit, 3 unit, 5 unit, 7 unit,
Yes.
not possible. Even 2 units is not possible. The dose starts with 4 unit. Why? Most of the guidelines suggest in type 2 diabetes that is starting bolus insulin is 4 units. So that is why it is started from 4 units. So 4 unit is the least dose that you can give with this inhaler insulin, or but you can up titrate it to 6, 8, 12 or whatever maybe it is. Depend, you require more, cartridges. So
So we don't have any data in the space of pregnancy at the moment, but yeah, that is ideally, as you heard, is the best area to use inhaled insulin. But as long as we don't have data, technically we would not be able to use it at this point of time.
yes.
Beg your pardon?
Yes.
Yes.
Type 1, yes.
Absolutely. Type 1 and type 2
So
in adults. Yeah.
type 1 adults, yes. So Supratik, can you go through these slides?
Okay. I think.
Then we'll ask them to show the device.
Yeah, I think rather than going through the slides extensively, we'll keep it more interactive. We'll ask somebody to demonstrate instrument. So there is a basic criteria. Let me go there. Okay, so this is my disclaimer, and thank you organizers for this invitation. We'd already talked about this, that we have gone a long way in terms of going from animal to human to recombinant DNA technology, analog insulins, but one thing that has never changed is that insulin has always stayed an injectable. So we have changed the device, we have changed the needle, it has become more easy, but one thing that has not changed is that insulin is still injectable. So it's a long journey that we had for the past 100 years, and whoever is interested, please have a look. This is how, this is called a freezer, which uses Technosphere insulin technology, and I'll tell you about the Technosphere technology in a while. But you can see the device that we had shown you, that's the delivery device, and on the right hand side, you see the cartridges, which is 4 units, 8 units or 12 units. এই পয়েন্টারটা কাজ করছে না কেন ভাই? এটা না? So 4 units and they're all color coded, so you can't go wrong.